Thank you very much, Margaret. Hi, everybody. Good to see you all. You know, I love long couches. I just went for a long run on Lakeshore. So how many of you are from Chicago? I love your city. I just went for a long run along the lake, and I'm really hot, so I had to bring a water up here. How many of you are in oncology research or in the broad cancer fighting industry? So this is one of the most intimidating crowds that I've been in front of. I am fortunate, thanks to Margaret Lowe-Smith and my partners at The Atlantic, to moderate almost every topic under the sun. And this is the one single topic that really intimidates me. It's so important to think about the human dimension of what we're talking about, but also to talk about science, the industry of things, costs, and to make an editorially smart conversation. Sometimes you have to ask uncomfortable questions. And I guess the one I want to start with you, Levi, is the question of the Moonshot Initiative. Joe Biden, whom many people appreciate, I do as well, and the president have put a lot of effort at the twilight of their administration. And I guess the first question I have, does that help or hurt?
Well, we'd like to think that it will help.
Yeah.
One of the reasons why there's reason for optimism is that I know many people in this room are aware that we're at a very special time in cancer fighting. There are armamentaria of drugs that we could never have dreamed of, 10, 15 years ago. And so, and there are already patients who have benefited who live years longer than they would have otherwise because of this. So I think there's an opportunity now to really accelerate the path that we've been on. Now, obviously, the flip side is that even with the amount of money that's been pledged, cancer is a vast disease. We all know there's so many different types, hundreds of different cancers, maybe more depending on how you slice it. So it would be naive to assume that by the end of the moonshot we'll have cured everything. But I do think that because of the progress and the excitement, there's a chance to really press on the accelerator.
I guess to go just a little bit deeper in that, and I want to feel as if the attention and the focus, I was with the vice president in Davos when he brought together people from the data world, people from the immunotherapy world, people from oncology, a whole variety of different folks. And I guess the question I was asking myself is, wouldn't this have happened anyway? In other words, with all of the changes, the research that you're doing, the room is doing, does an extra push really matter? Isn't gravity taking us towards some phenomenal leaps in any case?
Well, certainly we've benefited from the collective advances of science, and so so there's a pace that we're on already. But I can speak maybe even just anecdotally.
Right.
So I run a research laboratory. We do a lot of research into cancer precision medicine, which is the idea of matching the right drug to the right patient. And it's a very exciting area, but I can tell you that I spend a lot of my time raising money. So the idea of going around, well, we have an idea, but we've got to go find someone who will fund it. Maybe it's the government, maybe it's a company, maybe it's a foundation. So, and a lot of my colleagues are like that. A lot of my colleagues, there are the ideas, we all know what we want to do, but we have to spend a lot of time pulling together the resources to try to do it. So my feeling is, personally, that any infusion of resources that allows us to spend a little bit more of our brain power actually executing on ideas as opposed to chasing around resources to pay for it, I don't see a downside, but of course maybe I'm not a disinterested party in this.
Well, the other question I have in this, and today we're talking in part about rare cancers, about the field of this, is whether or not, in a room like this, whether talking about cancer as a basket of so many different things is really useful. I don't know the alternative. I'm not smart enough in this to know how you would do it in other ways. Other people may be there, but do we do it? Does the notion of cancer research need to be disaggregated more than it is today? Does that make sense?
Well, I think a certain amount of disaggregation is critical because we certainly know now for all of the new therapies that have come along that we have to stratify cancers based on the genetic changes, other molecular characteristics, because if we don't do that, we're going to end up misfiring. There's so many different therapeutic options. We have to have some rational framework for deciding which drug to give which patient. Now, I think what you may be getting at is, to its logical extreme, every single individual cancer could be unique. And are we really headed towards a world where literally every patient is going to get a slightly different regimen? That I don't think so. I think there's going to be a certain amount of grouping that is critical. But stratification at some level, based on our scientific understanding, I think there's no way around that.
So when you're asked today to talk about the next steps, the next things we might expect in rare cancer research and cancer research in general, what is the crystal ball you have about what the next big leaps are, the strategic leaps in the field?
Well, I think the first point to make is that rare cancers are actually common. Meaning that even when we talked about stratification, so when we talk about lung cancer or bladder cancer or breast cancer, increasingly we're recognizing that subsets of those cancers, they may be much less common, but the features that define them can sometimes have crucial therapeutic importance. So I think the first principle is it gets back to this stratification. It means that we have more groupings, and those groupings there are maybe relatively small numbers of cancer patients with those groupings based on genetics or what have you, but it's critical to know that because that's where the heart of precision medicine lies, taking those subgroups and saying these patients should get this targeted therapy or these patients should get this immunotherapy. So I think understanding the rule book about how to do that across all cancers is really one of the next big leaps. And another is going to be in understanding how to give not just one drug at a time or one regimen at a time, but how do we build combinations of regimens that are equally smart. So the reason why I press on that is because most advanced cancers cannot be cured with just kind of one drug or one. Often we have to give 2, 3, 4 or more drugs over the course of treatment. So how do we come up with the right way of combining these new classes of drugs and knowing how to do that for each patient that walks through the door? And then maybe the other big area is in the idea of data sharing and really coming together, getting out of the institutional silos and figuring out how to carry out the research. Because since rare cancers are common, what that means is no individual cancer center will have enough patients to really understand whether or not a new therapy works. We have to be able to break down traditional barriers and work together so that we can understand how to use drugs.
What is the ecosystem of research in this like? I know that many of you are here because there are big meetings happening and starting either today or tomorrow in Chicago. My colleague Van Newkirk in The Atlantic, you were interviewed in that piece, wrote a fascinating story of how accidental and serendipitous so much of the cancer field is. There's a story of a guy with, I think it's called Merkel syndrome, who accidentally heard about a trial going on in Seattle and got connected with that. And his story is an extraordinary one because he sort of empowered himself, understood that the treatments he was getting were irrelevant to what he had, and then took responsibility. But it sounds, if I can be candid, a little Keystone Cops-ish. And so I'm wondering how, as people out there, as citizens, what degree, how much of it is chaos, how much of it is ordered, and how would you improve it if you were really powerful?
Well, it's a great question. Everybody in this room probably knows about the age-old quote, "Chance favors the prepared mind." We in science and in medicine, there's a certain amount of chance, but in reality, a lot of that chance has to do with really smart people, dedicated people pushing and pushing, and then finally there's a breakthrough. And maybe we didn't see it coming, but in hindsight, our scientific advances have helped sort it out. I think immunotherapy, harnessing the immune system to fight cancer, maybe is in some ways an example of that. I think nobody saw the magnitude of the impact that immunotherapy has had in recent years, and yet, because of the aggregate scientific advances, we can make a lot of sense out of why we're seeing that impact now. So I think it's prudent to leave room for serendipity, because after all, we don't know everything. There's still a lot more that we have to discover. On the other hand, our aggregate scientific knowledge has brought us to the point where we really can accelerate.
So what are we discovering? I was just reading a little bit about your research, and you're famous for this quote, "the gene next door." What is the gene next door, and why does it matter?
Well, so I think what you're referring to is the fact that for many cancers, we understand scientifically, we know why, we know what genes got broken to build the cancer, but we're not always smart about designing new therapies that can target exactly what's broken. So in that situation, what was exciting was that in a particular, in a certain type of cancer, a certain type of gene alteration that's actually very common across many cancers, what we discovered is that there may be a new treatment avenue that's not targeting that gene directly, but it's targeting a pathway that all of a sudden becomes really important when that gene is broken. So those kinds of approaches, we haven't been able to do that as often, but that may be a new kind of avenue for developing.
What are some of the other promising tracks that you see at the moment?
So I would say
like genes next door.
Yeah. So, well, I think I'll get on the bandwagon and say immuno-oncology remains very exciting. We need to sort of play out what's the scope of patients who will respond to immunotherapy, and can we build new kinds of immunotherapy that will push even further. I think also understanding why when a patient benefits from a cancer treatment and then the cancer stops responding, it comes back. Why does resistance to therapy happen, and can we come up with new approaches to overcome that? That's a big opportunity area. And I think also now there's the technologies that we can use to detect cancers. There are some very interesting ideas of pushing them earlier and earlier to see if we can use them for early detection, so that a cancer, when it's tiny and treatable, can we come up with more innovative ways of detecting cancer early, which I think a lot of people have rightly pointed out that it's exciting to treat advanced cancer, but it's much better to treat cancer when it hasn't spread. So I think early detection is another big opportunity area.
You sound so optimistic, which is terrific. It makes me feel good. A lot of people that have been in this game for a long time are cautious of that kind of optimism. And they said, we've been there before. There have been other times where innovators and leaders have been sort of crowned as those that have cured cancer. Can you sort of create a context for us on sort of how excited we should be, or just how cynical we should be at this moment? I usually thrive in cynicism and darkness, but kind of scale it out for me. Where should we be given what you know?
Well, so first of all, I think it is fair to say that it's not as though everybody who has cancer is walking away cancer-free. I mean, our hospitals and wards and clinics are still chock full of patients who are fighting cancer. So I'm not trying to be Pollyanna, so I think it's a fair point. On the other hand, when I entered the field, when I was training to do oncology as a medical oncology fellow, there were some cancers that were just so depressing, where now they are the poster children of what is exciting. And so melanoma, an area that I do research in, when I was training as a medical oncology fellow, no one wanted to go into melanoma clinical oncology because it was so depressing. There was nothing to do. There was only one drug or a couple of drugs to give, and they basically didn't work, or they made patients very sick.
How many years ago was
this? This is maybe 12, let's say 15 years ago.
Interesting.
So at that time, I started doing research on it because we thought there might be some promise for targeted therapy, and lo and behold, fast forward to now, both targeted therapy and immunotherapy have had major impact on melanoma. It's really moved the needle. The survival, even in advanced metastatic melanoma, today compared to what it was 15 years ago, it's changed dramatically. We're not done. I mean, it's clearly, it remains a problem, but it's a whole different disease. So when you see that, when you've lived through that, and you're still young enough that you could see some more, it's hard not to be optimistic. It's hard not to think, okay, it's hard. This is a tough disease, and it's not going to go away probably in our lifetimes. But it's hard not to be somewhat optimistic that we're doing the right thing, and this has to be the path.
So the collection of all of that work that you've been engaged in with many others apparently has had a profound impact on Jimmy Carter's health. And I may be mispronouncing this drug,
pembrolizumab, yes.
And he seems to be cancer-free and has a few more years to build houses and do other cool things. In the industry of cancer, what do we need to see to have whatever he received be sort of pervasively available to many others with the same problem?
So first of all, before I answer that question, I should point out that that example that you just gave is exactly why we should be optimistic. I mean, what you just described, I mean, he had metastatic melanoma, and he's cancer-free. That's pretty awesome. I mean, it doesn't happen to everybody, but the fact that we can say there's a new drug that came along and we can do that in some patients with melanoma, to me, that's a reason for optimism. So now the question is, how do we make it so that there are a lot more Jimmy Carters? So here's where, hopefully, this is coming back full circle to the question of the moonshot. I mean, what we need is to identify where our barriers are now and see if we can consolidate significant resources to get to the next level. So for example, in melanoma, there are a reasonable proportion of patients who will respond to these immuno-oncology drugs, some as well as Jimmy Carter, some maybe not quite as well, but still for a long time. But what about the other patients with melanoma that don't respond? What's the next breakthrough that we can get those patients to have an immune system response that's like Jimmy Carter? And there are several ways that we could think about it, but consolidating effort to address those questions, that seems to be a very sensible mandate. And so questions like that in other areas are what hopefully the moonshot can start to teach us how to address.
Fascinating. Now, this Merkel, I may be mispronouncing it, Merkel syndrome cancer that my colleague profiled is one of these rare cancers, apparently. Affects less than 200,000 people globally. And there are apparently a whole shelf of these. As you said, they're much less common. What's interesting is how do you, when you find a way to treat that, which apparently there is a strategy now and an effective therapy to deal with that, what is the spillover into other possible rare cancers? What is that looking like as an avenue of research?
Yeah, so it's a very good question. So in the case of Merkel cell carcinoma, what we know about Merkel cell carcinoma is that there are, even though it's rare, there are changes, mutations in genes in Merkel cell carcinoma that also the exact same mutations and combinations of mutations happen in other types of cancer, in subsets of lung cancer, and actually even in subsets of other cancer after treatment. So when cancer relapses, and if it's very angry, you can sometimes see these other alterations. So what that means is that there are cancers that come from different parts of the body, but when you look at the genetic and genomic lens, or look through the genomic lens, they're actually very similar. So this is why advances in a rare cancer, they're often not just confined to a rare cancer. There are principles that can be applied to other cancer types as well.
If you were going to be more in charge than you already are on all the advisory boards you've got, and you didn't have to do fundraising, but you were to reorder who the stakeholders were in cancer research and sort of taking us a step forward, is what we're doing today the right way to do it? I mean, I remember in Davos, we had data people from SAP who knew nothing about cancer, but they knew something about data. We recently did a program on autism where we had a guy from Google who was an expert in information management and trying to work with genomic cases of autistic children. So who are the missing pieces that you think are not part of classic cancer research that might help speed things up?
Well, I think certainly one area that I think certainly would be near and dear to many in this room is being able to bring the patients and patient advocates very close to some of the research that's happening. I think there are two reasons for that. One is that the patient advocates can be ambassadors to the community at large for what's happening, both the promise and the challenge. Sometimes that's an important mode of communication, but reciprocally, I think the scientists and the clinicians are often inspired by the experience that the patient advocates bring. So I think there's a positive mutual energy that can be brought there. The other area, I mean, again, this is probably one of those things, if you could go in sort of behind the veil of ignorance and sort of start the world all over again,
right.
It would be great if it were a little bit easier to put drugs together, oftentimes from different companies, different areas of expertise, to test ideas that are supported by science. I think right now, oftentimes there are many different hurdles that one has to go through institutionally, regulatory, and they're very important, but sometimes they can be compounded to the point where a lot of people spend their time making it logistically possible, and a lot more time goes into that than actually testing the idea. So I think if we could shift the balance while obviously maintaining patient safety and quality, but be able to shift the balance so it's a little easier sometimes to test an evidence-based idea in patients who otherwise have advanced untreatable cancer, that would be ideal.
You know, I want to ask you a question while I have you here, because you're obviously such a leader in the research side. There's another side when there's some people in the room who are living with and trying to deal with cancers they have themselves and work it through. And I guess in my own family, with my own mother who passed last year, I didn't realize how profoundly illiterate I was and my family was on what the options were out there. And I became very aware that, she lived in Oklahoma, that the literacy about cancer in Oklahoma is pretty crappy. And you moved to Dallas and it was slightly better. You moved to Baltimore, you moved to other places, and it was just a very uneven field. And I interviewed Sid Mukherjee, read his book, and it is an incredible testament of what the options were. I wish I had read it 10 years ago, 15 years ago. But I guess the question I have is how much of what needs to happen has to be a literacy-focused thing with doctors and folks with ailments, but particularly in the doctors and the physicians that are out there treating this, because I get the sense it's a very, very uneven field.
Yeah, it's a very good point. I think this is true for medicine as a whole, but particularly in areas like cancer where the science is pushing so fast. There can be, it's really true, the ability of a community oncologist in let's say some rural part of the country where they're not able to come to a meeting like ASCO every year to keep up with what's going on. And those people, actually, they have it worse because they have to treat all the cancers. I mean, every single cancer that comes to their clinic, they have to treat. So whereas in academic centers, maybe you keep track of one type of cancer, lung cancer or breast cancer, what have you. So yes, you're absolutely right. The knowledge and the dissemination of knowledge is uneven in this country. There are a number of efforts that are some which are targeting clinicians, some that are targeting patients to try to address that or to create connections that otherwise aren't there. I think, again, some people in this room are involved in those types of efforts. But that is a big gap, and I think having ingenuity from creative people in this country from various different sectors, social media and others, to try to close those gaps is going to be crucial.
Before I go to the audience, the other question I'm interested in, just in terms of research and where to apply research dollars, is someone from the White House once said, there are these fads that pop up where either a kind of cancer or some sort of ailment will get a lot of attention, but we need to fund mathematics, genetics research, physics, and other parts, because fundamentally at the level of manipulation, genetic manipulation and immunotherapy, it requires so many people. What would you say about the state of research, the priorities in research today? Is it healthy? Could it be better? Is there something missing?
Well, I think what you're getting at is philosophically, one school of thought in this way is that what you want to be able to do is, on the one hand, you want to really pile resources in areas that really clearly show promise. They've demonstrated that they're a major impact, and so you really want to push those. On the other hand, you want to also be sprinkling, because you just never know where the next breakthrough is going to come. There are technologies that are now taking the world by storm, genome editing technologies that didn't even exist 5 years ago, and they came from very fundamental basic research around, how lower microorganisms fight, what their immune system is like. So you just never know where the next breakthrough is going to come. So in an ideal world, you have a sprinkling where you're funding excellent people in their area, and you have that happening because that'll foster inquiry and curiosity, and it brings new people into the field, new ideas, and then when something takes off, you attack that with directed funding as well. So,
what is your next big hit that you haven't told anybody about yet?
Well, I would say that there's two areas that we're excited about. One is we think that studying what I mentioned, studying when a therapy has been working for a while and it stops working, the cancer roars back. Studying mechanisms for how that happens. We think that there might be some very interesting new possibilities for therapy combinations that could prevent that from happening in some cancer types. We're also excited about immuno-oncology. We have some interesting studies in the lab about maybe understanding, because unfortunately, even with immuno-oncology, there are cancers that are now finding ways to become resistant to immunotherapy. So we have some studies about how that might be happening, and we hope that might lead to new.
Thanks for sharing your secrets with us. Let me open the floor. You folks are smart on this. Did we have a question over there? Questions, comments? Right here. Bill Marovitz. We're going to bring you a microphone, Bill.
Can you tell me if anything's happening in the area of CoQ10 and its utilization in cancer therapy. I hear that there's some really miraculous breakthroughs, melanoma and others. But can you tell me about
I'm sorry.
So I didn't.
CoQ10?
CoQ10.
I guess you've never heard of it.
Yeah,
It's not my area of expertise, so I can't comment.
like the candor right here, Rudy.
Stand. Rudy Anderson. I'm with the Chest Foundation, so pulmonary critical care and sleep medicine clinicians. You guys touched on it a number of times when talking about health literacy, funding, as well as patients and patient advocates.
Right.
What do you think is what could be the biggest driver, especially when talking about rare cancers, of empowering patients to meet clinicians at a particular point, right? Because we've seen this in breast cancer, right? Those first walks were by people in honor or memorial of someone, but now it's breast cancer survivors because we had taken a different focus.
Right.
So how do we address that in that rare cancer space? Because when that happens, right, the funding comes, better health literacy, and a better communication between the clinician and the patient.
Great question.
Yeah, it's a good question. There's not sort of an immediately obvious answer, but sometimes when you're thinking about rare cancers, so like you said, in contrast to common cancers where eventually you can get an army of survivors who can sort of carry this literacy and advocacy forward. In rare cancers, what may need to happen sometimes is a celebrity, somebody who really has a broad audience and bully pulpit who can engage and become inspired. I've been quite impressed, and I'm sure many others have as well, when celebrities, actors, actresses, singers decide they want to take on a cause. They can have a huge impact and raise awareness about things that you had no idea was going on. I was recently at an event where I learned about Matt Damon's interest in bringing water to making it easier for access to water in third world countries. I never even knew about that, but he's dedicating a ton of his time. So I think having that would be one possibility, to see if one can cultivate celebrities, key opinion leaders in various popular realms that could be willing to take that kind of message forward.
We're getting close to the end. Let me just wrap up with a perhaps provocative question. A lot of people here are earnestly, very consciously trying to sort of change the world, make the world better in cancer research. Sean Parker, who was the innovator in Napster and first president of Facebook, just put a big chunk of money into immunotherapy. Someone shared with me that platform of immunotherapy is the next way states and nations will compete. That Sean was involved for a time in trying to lure away people from Penn Med in Texas to the University of San Francisco. And so I'm interested in the dark side of investment in research, to which it becomes the next big thing for states, for innovation, and for financial power. Is that, do you sense that there's a piece of that that's driving a lot of the investment in cancer research?
Well, I suppose there's always a balance between the greater good and the need for individuals and institutions to survive, and so there's always a tension. One hopes that it's a positive thing. If there's competition, what that means is competition for the best drug, and no matter what, a patient's going to win. But obviously, sometimes there, as just in every realm, there's human nature and politics, and there's a risk for a dark side. To my mind, I guess it's a chance I'm willing to take. If there are people like Sean Parker and Bloomberg and others, and Vice President, who are willing to throw resources to improve the lives and the outcomes of patients with cancer, yes, I strongly believe that sometimes the darker forces of human nature are going to win out, but I'd rather see the effort made because of what we've been talking about, because I think that it's an even bet that we can make a lot of progress.
Okay, I feel better now. Ladies and gentlemen, Dr. Levi Garraway of the Dana-Farber Cancer Institute, thank you so much.